Hello everyone. So today we will be discussing about the diabetes in pregnancy. Okay, this is a very small topic. Sometimes question come and sometimes it doesn't come. It's a very small topic. So the subtopics in which we are going to discuss this topic is, first of all, we will see how to diagnose this problem. Okay, and then what are the maternal and fetal complications. Then how to manage the diabetes. Okay, so let's start. This is a question from Inicet November 21. Okay, according to IDPSG. So first of all, I want to tell you there are four groups which related to diabetes. Okay, which give us criterias. As two groups agree on same thing, so you can say there are three groups. So basically, the four groups are there of diabetes which give us recommendation and criteria. Okay, number first is IADPSG. Now here I stands for international, so it is a international association of diabetes pregnancy study group. Okay, so it is a special group who studies the diabetes in pregnancy. Okay, special association. And the another group which also follows, whose both recommendation are same, is ADA. Okay, American Diabetes Association. They both say one and the same thing. Okay, now on the number 3 is the Indian group, that is DIPSI. Okay, first you have to see that this I stands for international, not for India, and this DIPSI is our Indian group. Okay, Indian diabetes group. And fourth is the ACOG. Basically, in Indian condition, we follow the DIPSI recommendation. They are more practical, but they do ask this IADPSG recommendation, so you should know them. Okay, so IADPSG and ADA, their both of their recommendation are same. Okay, so both of their recommendations are, both this group have same recommendation. So even if you learn IADPSG, same is the recommendation of the ADA. Okay, we will see how Indian is slight different. Okay, and how it's more practical. And the fourth group is the ACOG. So basically we have to learn the three recommendations. Okay, if you want to learn only one, do learn the IADPSG group. Okay, now let's see what the question is. According to IADPSG, the cutoff fasting sugar to diagnose a woman with diabetes by one-step method is. So they are asking one-step method fasting sugar. Okay, so let me tell you what does IADPSG and ADA recommends, and that they just gives one test to us to diagnose the diabetes in pregnancy. Okay, both the group says, IADPSG and ADA both says that a woman should be screened only once. Okay, please note it is only once at 24 to 28 weeks. Okay, at 24 to 28 weeks by 75 gram oral glucose tolerance test. Why they say that we have to screen at 24 to 28 weeks? Because the human placental lactogen, which has a insulinase action, its activity is maximum at after 24 weeks. Okay, its activity is maximum after 24 weeks, because human placental lactogen, it acts as insulinase, so it don't let the insulin to function. Okay, it acts as a insulinase, it destroys the insulin, so it does not let the insulin to function. So that is why it is said that pregnancy is a diabetogenic state, because in pregnancy human placental lactogen is released, so and human placental lactogen is nothing but insulinase. So it destroys the female insulin and cause hyperglycemia. Okay, so now because the activity of insulin is maximum after 24 weeks, so, and the patient is more prone to hyperglycemia at 24 weeks, so they say that do screen the patient only once in the whole 9 months, that is after 24 to 28, in 24 to 28 weeks. Okay, and the test which they recommend is 75-gram oral glucose tolerance test. Okay, 2 hour 75-gram oral glucose tolerance test. Here we need to tell the patient to come fasting. Okay, patient should come fasting, and we take 3 values. One is fasting, one 1 hour, and one 2 hour. Okay, okay. So if the fasting is the cutoff value for the fasting is 92, if it is 92 or more than 92, then patient is diagnosed as gestational diabetes mellitus. And if the 1 hour value is more than 180, then again the patient is diagnosed as more than or equal to 180, then again the patient is diagnosed as gestational diabetes mellitus. And the 2 hour cutoff value is 153. Okay, again the patient is diagnosed as gestational diabetes mellitus. Now if the fasting come out to be 126 and it comes out in first trimester itself, on the basis of suspicion we get this test done. Or if already patient says us ki I am having diabetes, and if the fasting come out to be more than 126, then it's a case of overt or pre-gestational diabetes mellitus. And the 2 hour value to diagnose overt diabetes mellitus is 200, more than 200. Okay, okay. So this is the recommendation of the IADPSG or ADA for the diagnosis of gestational diabetes and pre-gestational diabetes. Now DIPSI, what DIPSI says that in India, as patients are not aware, so DIPSI says that that no need to ask the patient to come fasting, because Indian patients, they are not aware. If today I tell the patient come tomorrow fasting, I don't rely that patient is going to come or not. Okay, so it's better whenever the patient comes, diagnose it. And Indian population is rather Asian population is more prone to diabetes, so we need to screen twice. Okay, first of all, DIPSI says no fasting because patient don't come back. Okay, and we need to screen twice because Indian Asian population is at the risk. Okay, so first one has to do the test at first visit, and the second is we have to do the test again at 24 to 28 week. Okay, now again as fasting is we don't patient didn't come fasting, so no advantage of doing the fasting values. Again we are not taking two samples, one at 1 hour and one at 2 hour, because Indian population doesn't want so much of hustle, so only one sample is taken after 2 hour, and the value is 140. More cutoff value is more than 140, and for overt diabetes mellitus it is same. The cutoff value for the 2 hour IADPSG was 153, but for the cutoff value for as per DIPSI is 140. It's just a 13 value variation, but you should know. Okay, but over diabetes values are same, 200 and 200, right, for both. Okay, so as you are seeing that DIPSI is more practical, so in India we follow the DIPSI, but questions are asked, so you should also know this. Okay. So here the question was, according to IADPSG, the cutoff fasting sugar to diagnose a woman with diabetes by one-step method. One-step method is just I will tell you what is why they are saying one-step method. So the answer here is, see, they have given very the values are very nearby, 92, 90, 95. So they are very nearby. So you should remember the exact value. I always say that there are some things that you can't skip learning, skip the rectification. The one thing is diabetes values. Okay, so those who are like me, who forget very easily, just listen. It is 92, and the 1 hour value is 180. You can remember it like this. See, 90 into 2 is equals to 180. So the fasting is 92 and the 1 hour is 180. Then it is 153 or 140 in the dipsy. Okay. Chilling. That's good. Now another question, same question was asked in this is I think in INICET 2019 and Inicet or 2000, I think November 2000. For diagnosis of GDM, FBS should be here, as there is no value of 92 is given. So here we took the 95 as answer. Okay. So once again I'm telling you, 126 is to diagnose the overt diabetes mellitus. Okay. 140 is the 2-hour dipsy criteria, and 200 is a 2-hour overt, this is fasting, and 200 is a 2-hour overt diabetes mellitus value. Okay. Now this was a question which is asked in FMG June 18. Now they have asked cutoff value of 50 gram glucose challenge test at 1 hour. Okay, at 1 hour. Now this is the one criteria which we left was ACOG criteria. Now this is as per those criteria. Now we will see what ACOG says. ACOG has given us 2 tests, one screening test and one diagnostic test. Okay, so they say that whenever a patient comes, any pregnant patient comes, do the 50 gram glucose challenge test. Okay, regardless of the fasting, we have to do the 50 gram glucose challenge test. Okay, so it is done in all pregnant women, and its 1 hour value, if it is more than 140, then we have to do the diagnostic test. Otherwise we have not to do the diagnostic test. So there we learned the 140 after in the dipsy 75 gram oral glucose tolerance test. There we learned the value was 140 after 2 hours. So you just keep notice, this 140 value is after 1 hour. Okay, in dipsy 2-hour oral glucose tolerance test, the value was 140, right? 75 gram, right? But here now after 1 hour, they are saying that if it is more than 140, then we have to do the glucose tolerance test, and then that will be the diagnostic test. Okay, if the value is less than 140, then it is not needed. Just to tell you one more thing, that ACOG is not recommending the 75 gram oral glucose tolerance test, 2 hour 75 gram oral glucose test. ACOG is recommending 100 gram 3 hour. So there, as the test is 3 hour oral glucose tolerance test, so we have 4 values. Okay, so those values are fasting 1 hour, 2 hour and 3 hour. Okay, so I just don't want you to confuse with those values. So I'm just telling you that its first 3 value, fasting 1 hour and 2 hour, are almost same like the 75 gram oral glucose tolerance test. Okay. Okay, so I hope you will be able to differentiate what are all the four diabetes group and what all they recommend. Okay. Okay, now this is the FMG December 21 question. Not a feature of baby born to diabetic mother. Okay, now till this we have diagnosed the patient. We have done all the four diabetes group recommendation. Now we will see what all problems come in the fetus, in the mother, and in the newborn. So they are two different things. In the fetus, a different set of complications are there, and in the newborn, once it has delivered, different set of complications are there, so that you don't get confused. I am discussing all them here. Okay, so here they are telling us not a feature of baby born. Baby has been born. Okay, of a baby born to diabetic mother. Okay, so let's see first all the complications, then we will solve this question. So first of all, what are the complications in the fetus? As you know, glucose value, they quite often they get dearranged in the diabetes patient, so the chance of abortion and IUD is always there. Okay, and the fetus has macrosomia. Fetus is of large size. Okay, and the hyperglycemia is there in the fetus. Okay, so these are all the fetus complication. Okay, only these three complications are there in the fetus in utero, in the uterus. What are those complications? Once again, that fetus can have abortion, that fetus can abort, or IUD can occur because glucose level derange a lot, and there can be sudden hypoglycemia or hypoxia, so fetus can abort. Okay, the next is that fetus, most of the fetus, they undergo macrosomia, and hyperglycemia is quite often seen in the fetus of the diabetes mother. Okay, these all. Now once the fetus is born, in the newborn or in the infant, they ask like this: what are the complications in newborn or the infant? Now these are the things which are happening after the delivery. Okay, so now let us see. So you can see here, one side we have written all the hypo things. Okay, hypoglycemia. Now all the hypo are happening. Okay, okay, now why hypoglycemia occurs in the fetus once the fetus is born? Because when the fetus is inside the uterus, then beta cell hyperplasia occur, and once the fetus is born, so the body doesn't get adjust the hyperinsulin which was being secreted to balance the hyperglycemia. It keeps on secreting even after the baby gets delivered. So due to the hyperinsulin secretion, the baby suffers from hypoglycemia. So it is quite common as the fetus has hyperglycemia and the baby has hypoglycemia once it's born, because baby does not adjust very early to the condition. Mother has hyperglycemia, in the same way the fetus has hyperglycemia when the fetus is in the utero. The hypothesis which explain this is Peterson hypothesis. Okay, but once the fetus is born, fetus suffers from hypoglycemia, and all the ions, they are in the hypo condition: hypophosphatemia, hypocalcemia, hypokalemia, and hyponatremia. Why is it so? It is so because the hypophosphatemia and hypocalcemia are there because the parathyroid gland, it activates late in the infant of diabetic mother. So there is hypophosphatemia and hypocalcemia, and hypokalemia and hyponatremia are again due to the deranged glucose level. Okay, now why the infant of diabetic mother also suffers from, you can see here in the right side it is written hyperbilirubinemia and polycythemia. Why there is hyperbilirubinemia and polycythemia? Because you all know that the infant while in utero has been suffering from chronic hypoxia. Okay, there is delayed lung maturity and there is a chronic hypoxia. That is why we do fetal surveillance again and again. So due to that chronic hypoxia, there is increase in the erythropoietin level and it leads to the increase in the RBC production, which lead to polycythemia and hyperbilirubinemia due to the hemolysis of increased production. Okay, so hyperbilirubinemia is also known as jaundice, you all know. So that is why this condition is there, and this condition is also known as hyperviscosity. Okay, so due to the increased erythropoietin levels, due to the chronic hypoxia suffer, there is hyperbilirubinemia and polycythemia and hyperviscosity syndrome, and rest all the ions are in the hypo and glucose is also hypo. Okay, I hope you understand. Now let us see this question. Not a feature of the baby born to diabetic mother. It was asked in FMG December 21. Okay, so options are hyperglycemia, hypocalcemia, hypophosphatemia and hyponatremia. So it is quite often asked. So the answer is hyperglycemia, because once the baby is born then there is the baby keeps on secreting high insulin. Due to the high insulin secretion, baby goes into hypo, not in the hyper. Only two hypers are there: hyperbilirubinemia and hyperviscosity syndrome or polycythemia. Okay, no other hypo is there in the infant. Okay, now let us discuss the congenital anomaly. First and foremost, you should be clear of the concept that as discussed already, that the gestational diabetes mellitus, it occurs. Yes, it occurs. Gestational diabetes mellitus, it occurs after 24 weeks. Okay, and by 24 weeks, all the organogenesis is completed. So a baby or the fetus of the gestational diabetes mellitus will never suffer from congenital anomalies. Only the patient of overt diabetes mellitus or pre-gestational diabetes mellitus will suffer from congenital anomalies. Okay, or do make this concern. Okay, in your clinical practice also, and here in the exams also, only and only the fetus of the pre-gestational or overt diabetes mellitus will suffer from the anomalies, because during the organogenesis period, only there the glucose levels are deranged. Whether in the because the gestational diabetes mellitus come after 24 weeks, so no congenital anomaly occurs, and no congenital, not even a single congenital anomaly occurs in the fetuses of the gestational diabetes mellitus, because by the 24 weeks all the organogenesis have been completed. Okay. Now next here is what are the congenital anomalies suffered by the fetuses of the overt diabetes mellitus. Okay. Now most common system which is affected is the cardiac system, and most common anomaly is the ventricular septal defect. Okay, but the most specific cardiac anomaly which occurs in the fetuses of the pre-gestational diabetes mellitus is the transposition of the great arteries. Okay, so most common system which is affected is the cardiac system, or you can say cardiac anomalies occur quite often in the fetuses of the overt diabetes mellitus. The most common anomaly which occurs is the ventricular septal defect. Okay. We have done practice a lot of questions, okay, on all this. And the second most common system which is affected is the nervous system. Okay, and the most common nervous system and anomaly which occurs is the neural defect. Okay, rarely, but most rarely this anomaly happens, skeletal anomaly, but it is more specific. It occurs only and only in the patients of the over diabetes mellitus fetus. Nowhere else is this deformity recorded, and it is sacral agenesis. Sacrum is not formed. Okay, I haven't seen any case. I have just seen it on Google. Okay, so you can see that how rare it is. But yeah, this defect is only and only seen in the overt diabetes mellitus fetus. Otherwise, it is not seen. Okay. Best method to now, if we want to know that this lady is a pregnant lady, is a patient of overt diabetes mellitus, how much is the risk? Either it is high risk or low risk. Then we should know the how much is its glucose level deranged. More are the glucose level deranged, more are the chances of more are the glucose level deranged, more are the chances of anomalies. Okay, so and the glucose level 3-month data is given by the glycosylated HB or HbA1c. Okay, and HbA1c tell us the risk, whether the pregnant lady is a high risk or low risk. But the best method to diagnose the anomalies, of course, ultrasound. Ventricular septal defect can be easily diagnosed on ultrasound. Okay. So maternal complications are not asked in the question. They are asked in other topics, but just to tell you, because these integrated questions are asked. So, a lady with the gestational or overt, both cases, the maternal complication is that there is polyhydramnios, because due to the hyperglycemia, the fetus suffers from polyuria, and amniotic fluid is nothing but the fetal urine. So, there is polyhydramnios. Okay, there in the amniotic fluid, they're very fond of asking that amniotic fluid gets reduced in renal anomalies, because in renal anomalies urine is not formed, and that is why. And there in the one option it is written gestational diabetes mellitus, okay, or diabetes in pregnancy. So there you have to just remember this, that because the fetus of the gestational diabetes mellitus suffer from hyperglycemia, so there is polyuria, and this polyuria leads to polyhydramnios. It does not lead to oligohydramnios. And you know that we have read that the fetus of the diabetes mellitus is macrosomic. It is a large fetus, so the uterus gets distended a lot due to the large fetus and due to polyhydramnios. So there are high chances of PPH. So it is also asked in PPH that whether the patient of polyhydramnios or diabetes are at the risk of PPH or not. Yes, they are at the risk of the PPH. Okay, so now let's see the questions. This was asked in NEET PG 2020. In fact, born at 37 week of pregnancy with body weight of 4.5 kg. So the body weight is more, the baby is macrosomic. Which of the following condition is associated with mother pregnancy? Anemia, APH, thrombocytopenia, diabetes mellitus. Yes, now you know that the diabetes mellitus fetuses are prone to macrosomia, because hyperinsulin in them leads to hypergrowth. Okay, lead to macrosomia. Okay, now one thing I would like to tell you, that if in any question they ask you that what is the fetal complication of the gestational diabetes mellitus fetus, then you spontaneously you have to say it as macrosomia. Okay, so what is the complication, fetal complication of the gestational diabetes mellitus fetus? Because now you know that no anomalies occur in the gestational diabetes mellitus fetus, so only and only macrosomia will occur in them. It also occurs in overt diabetes mellitus, and it also occurs in the gestational diabetes mellitus. Okay, so the answer to this question is diabetes mellitus. This is a question which is asked in NEET PG 2020. Which of the following condition in the mother is considered a major risk factor for the fetal anomaly? So examiners are very fond of asking the rare things. That is why I have put this image. So this is a patient, this is a baby with sacral agenesis. There is no sacrum, as you can see in its x-ray also. So sacral agenesis is only and only found in, now you see the question has also come whether it is found in gestational or pre-gestational. Anomalies are always found in the pre-gestational or the overt diabetes mellitus. So the answer is B, pre-gestational. Next question. Now we are on the last part of diabetes in pregnancy, and it is how to manage. We have diagnosed the condition by 75 gram oral glucose tolerance test and DIPSI criteria. The values were 92, 120 and 153. Okay, and in DIPSI it was 140 and 200, and 140 was for the gestational and 200 was for the overt. Okay, there only one value is taken in the DIPSI. Okay, FMG December 20 question is that a pregnant woman at 26 weeks underwent glucose tolerance test. Okay, and the fasting sugar was 130. As you can see, it is a more than 126. So it is a case of overt diabetes mellitus, and 2 hour post glucose load were 200. So 2 hour is 200. So in both the values are indicating that it is a case of overt diabetes mellitus. What is the best step? So here I would like to tell you, if any of one value is crossed, here two values are crossed, if any of one value is crossed, we need to give the patient insulin. Okay, and in both, in hypertension and in diabetes, we have to admit the patient and we have to fix the dose. Okay, in both hypertension and in diabetes in pregnancy. Okay, we just need to we will not do the estimations. Yeah, your values are this, so this much insulin will suit you. No, we have to admit, we have to check, because if hypoglycemia will occur, then the fetus will die. Okay, that is why we need to admit the patient, monitor the RBS and fix the insulin doses. Then, so answer is, here is B, admit RBS, monitoring and start insulin, and this is a case of overt diabetes mellitus diagnosis. Now let's see the management. Yes, of course, we will start the insulin if the patient has reached the cutoff value. Okay, insulin is a drug of choice. Beside that, we can also give the diet control, and we can also give the diet. We have to also ask the patient to do the diet control, decrease the calories, and and do the exercise. Exercise is just simple 30 minutes walk. Okay, what about the calorie advice? It was once, I think it was asked in exam. So normal the calories which a female take in pregnancy is around 40 kilocalories per kg. Okay, and here if the patient has diabetes, as we have to reduce the calories, now we'll give up to 30 kilocalories. Okay, 30 kilocalories per kg per day. Okay, you have to remember these data. These are asked. Okay, because these are quite common problems, they do ask. Okay, Then next is exercises, just 30 minute. And recently, not so recent, it has happened 6-7 years back, as it was seen that Indian patients were not easily adaptable to the insulin injection. So it was found, the WHO approved two oral drugs, oral hypoglycemics, and they are metformin and glibenclamide. The another name of glibenclamide is glyburide. Okay, only two drugs are approved for those who don't take injections of insulin. Okay, they hesitate, for them these are the drugs, but never forget that insulin is always drug of choice, and insulin does not cross the placenta. Okay, in hospital insulin dose is set once, and again I'm telling you. So targets, what are the targets, what should we want? Key glucose should be at this level, then we will say that the pregnancy will go fine. The targets are fasting less than 95, 1 hour less than 140, and 2 hour less than 120. Okay, okay, so one more set of values you have to learn. Okay, fetal surveillance, but here I would like to tell you that those values in the diagnosis are asked quite often, these are asked less often. Okay, so targeting values are these, and fetal surveillance is done quite often, that you all have studied in the fetal surveillance. Okay, now one major problem which is suffered by the fetuses of all the diabetes, gestational and overt both, that the fetal lung maturity is delayed. So as you all know that fetus is, due to the chronic hypoxia, fetus get abort and fetus get IUD, but it doesn't mean that we are going to deliver the patient early, because even if the patient we deliver it early, thinking that might IUD occurs, the patient does not survive, because fetal lung maturity is delayed in all these patients. Okay, so we need not to deliver the patient early, that is quite often asked. Okay, so even at in some hospitals steroids are given at term. Okay, because fetal lung maturity is delayed in these diabetes patient. Okay, now steroids, they increase the sugar, but they are not contraindicated, and but it is told that one needs to admit the patient and give the steroid. Okay, and monitor the sugar and accordingly increase the insulin for those interval of steroid. Okay, now what is the time of the delivery? Late to late we have to deliver the patient. If it is the diet controlled gestational diabetes mellitus, because it's a common diabetes we see, if it is diet controlled, okay, gestational diabetes mellitus, then we have to deliver the patient at 40 to 41 week. Okay, we can also cross the 40. Okay, and if it is a drug controlled, then we have to not touch the 40, we have to deliver it after 39 and 239 weeks 6 days. It is the most common question asked when you will deliver the patient whose diabetes is controlled, because this is the most common category of the patient we get in the practice, clinical practice, that the patient is gestational diabetes mellitus. Overt diabetes mellitus is seen very less often. So if the patient is gestational diabetes mellitus and it is drugs controlled diabetes, on insulin the glucose are controlled, then we will deliver it at 39 weeks to 39 weeks 6 days. Okay, and this is very asked, you will see 2-3 times they have asked this question. Okay, and if it is overt and it is the controlled on drugs, then we have to deliver at 37 to 37 weeks 6 days, and if it is uncontrolled overt, then we have to deliver at more than 34 weeks. Okay, so this is a question which has come in Inicet May 22, incorrect regarding the diabetes. Now here they have asked a new thing. Okay, usually in labor management was not asked, but here they have asked it. You will see here. Elective cesarean does not increase the incidence of brachial plexus injury. No, there is no shoulder dystocia in the cesarean. Okay, shoulder dystocia is only seen in the normal delivery. No shoulder dystocia, so no normal delivery. Shoulder dystocia is seen in the normal delivery. So in the cesarean, if the shoulder gets stuck, then we increase the incision. So no brachial plexus injury is there. This first statement is correct. The second statement is in active labor. Now they have asked how you are going to manage the patient in the labor. So here I would like to tell you, in labor, because the patient is undergoing labor, undergoing contraction, sugar levels, they do fall. Okay, we monitor the sugar level every hour. Okay, patient is has a tendency of hypoglycemia, so we monitor the glucose level every hour. Okay, and if in the labor the RBS is less than 70, then 5% dextrose is started. What is the indication of starting the 5% dextrose? RBS less than 70 and the rate is 100 to 500 ml per hour. Okay, in a patient for induction of labor, now if we are going to take the patient tomorrow for induction, then we are going to miss the morning dose of insulin, because we know once the patient gets into the labor, then the patient will suffer from on the hypoglycemia. So we are not going to give, we are going to miss the morning dose. Night dose is given and rest is about the monitoring levels. Monitoring levels are same. So the incorrect answer here is this: morning insulin dose is given. No, it is not given. So that all about the diabetes in pregnancy. Thank you.